Thank you everyone for putting on this event today. This is amazing and we're really excited to share this work. Shelly and I have presented together at SUNY Delhi and at other places, and we start with talking about adverse childhood experiences and then trauma-informed care. And we'll touch on some statistics and also just a content warning. Some of the information can be upsetting for people, so please take breaks as needed. And here are our objectives listed here, and I kind of talked about, so we'll be introducing, and we're going to talk about strategies at the end. So just to start, what are ACEs? And it's adverse childhood experiences. So stressful or traumatic events that children are exposed to in their community or in their home. It could be repeated events that occur over and over again, or it could be, something that like a one-time event. It could be either or. And I want to also just talk about trauma. What is trauma? Because we're going to be talking a lot about ACEs and trauma, so definitions are always really important. Individual trauma results from an event, a series of events, or set of circumstances that is experienced by an individual as physically or emotionally harmful or life-threatening, and that has lasting adverse effects on the individual's functioning and mental, physical, social, emotional, or spiritual well-being. And that definition is right from Sam Hassa. So that's, I just always like to define things before I start talking about them, so we're all on the same page. And also it's really important to talk about collective trauma. So this term, has anyone heard of this term, collective trauma? Okay. And we're all sort of in a collective trauma post-COVID, and other traumatic events occurring in our world and in our country, but it refers to the psychological reactions to a traumatic event that can affect a society. So I think many of us can think about many things that are going on that we've all collectively are experiencing, and some people are experiencing it different than others. And then the different types of trauma: acute trauma, chronic trauma, complex trauma. Acute trauma is more short-term trauma, so that's that one-time event, house fire, car crash, something happening, an assault or a sudden death of a loved one, so that's acute. And then chronic trauma is with that sustained, repeated type of trauma, persistent bullying, neglect, abuse, any type of abuse, domestic violence, combat, and human trafficking. And complex trauma can arise from experiencing repeated or multiple traumatic events from which there's no possibility of escape and can impact an individual's ability to trust. So this is this type of trauma is definitely more complex, and it's can be like systematic and historical oppression, intergenerational poverty, discrimination, and all sorts of that type of complex trauma. So harder to put a finger on for some people objectively, but the people experiencing it are really experiencing it. So it's important to really talk about that and explain how that complex trauma can impact our society and our relationships. So I'll talk a little bit about the original ACE study, and I know most of you know about it, but some of you are unfamiliar. So the original ACE study was actually done in 1998, and it was done by Dr. Vincent Felitti and Robert Anda from the CDC. And it really was started because Dr. Vincent Felitti, he worked at Kaiser Permanente, which is in San Diego. It was an HMO at the time. And he was doing an obesity study. And he was having excellent outcomes at first, but then he saw that there was a high relapse rate. So he started doing post-evaluations of his patients who were relapsing, and one of the key things that came out was many of these individuals experienced early sexual abuse. So from that, he thought, well, there's something more here. And I forget how they met, Robert Anda, but they met somehow by accident. Dr. Robert Anda had worked for the CDC, and he was doing public work, I believe, in smoking in the public. And you can help me here, Shelly, because I know you know a lot about this. So somehow they met and they decided to collaborate and got the sponsorship from the CDC to do the largest study of all kind of its time and our time. I don't think a study like this has ever been done. So through the access with an HMO of Kaiser Permanente, they had access to thousands and thousands of patients. So they were able to, about 17,000 patients from that HMO in San Diego responded to this survey. So this was a survey that they were sent in the mail because it was in the 90s, and these were people who self-reported, and they chose, it was optional, they chose to respond to the survey. So they didn't get, obviously, every member of that HMO, but 17,000 of them responded. And they voluntarily participated. This is the ACE questionnaire, and we do have copies up here if you guys want to see them. They're at my table there. So what do ACEs include in this study? Emotional, physical, or sexual abuse, childhood neglect, emotional or physical, household dysfunction, which can be domestic violence, parental discord or divorce, mental illness, substance abuse, crime, parental incarceration, I believe, is the last one. So the ACE study population, just, again, quickly to sum it up, a majority of the population were Caucasian, because remember, this is HMO, Kaiser Permanente in San Diego. Most of these individuals were employed and had insurance through this HMO, so they did not have any patients who were on Medicaid. I believe there were some Medicare patients in there with the older population, but this was an employed population of individuals who had this healthcare insurance through their employer. Most of them were working and had jobs. So this is the breakdown. And then this is a breakdown of the education. So a majority of the population attended college or graduated or, in higher ed. And the number of ACEs, and there's a lot more, so if anyone has any more questions about the details of the ACE study, please ask us, because there's a lot more to it than just what we're showing here. But some of the things that we're pulling out, I think, are pertinent to this conference today. So what they found is ACEs are common, and 2 out of 3 people have experienced at least one ACE, and 1 out of 8 have experienced 4 or more ACEs. And I think this slide's really important because if you look here, I don't know if part of it's cut off there on the left, but individuals with an ACE score of 4 or more were more likely to, 12.2 times more likely to have a suicide attempt, 10.3 times more likely to have injected drugs, 7.4 times more likely to be consider themselves an alcoholic, 6.6, I can't see that from here, but I think it says 6.6, more than 14 days, missed more than 14 days of work. So they're not contributing, they're not making money, they're not able to keep a job. That's that economic toll that is impacted by that. And they also discovered that ACEs has a dose response. So the higher the ACE score, the more intensity of the health outcome. So the greater the intensity of the health outcome. So this slide is from the CDC, and if you can see here, it's color coded there, and health, it tells you all the health outcomes that are impacted by ACEs, behaviors, and life potential. So you see again, sort of that economic toll to that individual and to society. And this is a great slide. I believe this is from the Institute of Family. I think it says it's cited down there, but it's a really good slide, and I've seen it, through the years learning about ACEs. But it really gives that oil spill. So this oil spill is showing the population attributable risk. So ACE reduction will reliably predict simultaneous decrease in all of these conditions. So this oil spill, it's like an oil spill there, and it's just showing you the statistics of the risk of these vulnerable populations of people who are affected, who have higher ACE scores. They're more likely to have HIV. They're more likely to have anxiety, mental health, medical treatment, on psychopharmacological medications, hopelessness, mental health conditions, life dissatisfaction. I mean, all of them there, and it just shows you the percentages. So I think for One thing that's not on this slide, which it just wasn't there, they don't really talk about specifically opioid use disorder.
So before I dig into the neuroscience behind ACEs, I just want to say, one of the things that we didn't mention this morning is that the impact of trauma can be both direct, which is what Libby talked about, but it can also be indirect. And I just want to acknowledge, for many of us in this room, we are exposed to the trauma indirectly of every single person we work with every single day. And even though we're not talking a lot about vicarious trauma today, I want to put that out there as something that is important for this group and others to be aware of and to talk about and strategize around, because that's the only way that we don't get burnt out and that we can continue to do the hard work that we do every day. So I just want to acknowledge that. The other thing I want to acknowledge real quick is that here we are at this summit about substance use disorder, and in previous workshops we've been at, maybe it's been about mental health, maybe another time it's been about diversity, equity, and inclusion and belonging. And it kind of doesn't really matter where we're at. This topic of trauma-informed care and how to be trauma sensitive always is part of kind of the foundational conversation. And so much of what we're talking about in all of these different places that we find ourselves is how do we help people who have experienced some sort of trauma and reduce some of those behavioral or health outcomes that are so easy to, I think sometimes we have a tendency, to sometimes ACE scores can feel like a label. And so how do we, going back to what Julia said this morning about destigmatizing, how do we help the community build resilience and overcome adversity instead of that being like a label or a sentence that you have because you had these experiences in your childhood. So we'll talk more about those strategies as we go.
With the ACE study, there have been so many ACE studies done after that ACE study with the same findings. That's why we've come to the point where this is how it is. And it's globally, there have been ACE studies done across our whole, our nation and different communities, and they even extended it to communities with community violence. And there are some researchers who have an ACE tool that actually adds community violence and discrimination in their questionnaires. So again, this is not just that one ACE study, that was just the original, and then that spurred this research throughout our whole globe. This is, again, not just in our nation. So that was the seminal study, and it's at this point, this is what we're finding.
Thanks,
so
Libby.
It's been accepted, as evidence at this point.
So back in the 90s, when the original seminal study was conducted, there wasn't a lot of information about how trauma impacts the brain. Well, what they knew is that there was this correlation between these adverse childhood experiences and these behavioral life health outcomes. But there wasn't really, at that point in time, a real understanding. And I always share this story because I was a little starstruck, geez, can't say that 5 times fast. I had the opportunity to become a trainer for an evidence-based model that Dr. Anda, one of the original investigators, and one of his partners, Laura Porter, developed. And listening to him talk about the study, if you're interested in this, it was like, I was just like in awe. But he talks a lot about this information that was missing initially, but that we now know, which is why it's so important, I think, that we get out there and we educate and we talk about this, because we now have indisputable scientific evidence to back up what we've maybe known for years about how trauma is impacting people. So we're just gonna share a little bit about that. The one thing I kind of want to start by pointing out is our response to stress, to toxic stress, is biological. And so often, I see this with my agency all the time. So I have about 200 staff. We provide a lot of emergency services, not just around substance use, but around all areas. And so often we get that client who's agitated, they're angry, they're swearing, they're yelling, they're mad. And my staff, what's our natural reaction to somebody like that? To be defensive, to put our guard up. And what we constantly have to remind ourselves is that their behavior in that moment really has little to do or nothing to do with us. It's their response to the stress that they're experiencing. And so some of us shut down. Some of us get angry. Some of us run away. That response is biological, and it's hard sometimes to pull yourself back out of that and meet people where they're at, which is what I think probably everybody in this room is working to do, or you wouldn't probably be here today. But I think when we can be mindful of that and take ourselves out of the equation, it helps us to realize like that response really is just their biology kicking in, saying this is how we have to protect ourselves. So in terms of stress responses, you know, when we're under a lot of stress, you know, our heart rate kicks up. You know, our body is equipped to deal with a certain amount of stress. So I think about this like pre-COVID, right? We all had a baseline stress level. We also had coping strategies to deal with those stressors because that's how we get through every day. What happened during COVID, everybody's stress level went up, and oops, there's no time to come up with new coping strategies. And we all know when you're in the middle of the crisis is not the time to come up with new coping strategies, right? And not only that, but for me in particular, and probably for some of you, the coping strategies I had all of a sudden became things I wasn't allowed to do. So my stress level went up, and I had less coping strategies. And so our bodies are not equipped to live in a constant state of fight or flight, a constant state of high level stress. And when people, and we all work with a lot of people, and maybe have been that person at some point in our own lives, who are in that constant state of fight or flight, and they can't get out of it. They start to see every situation in their life as a fight or flight moment. Think about how hard it is to help move people to change if all they're thinking about, whether they know it or not, is fight or flight. I need to survive. And so, you know, I always say to my staff, like, it's great that we want to help this person get a job, but we really kind of need to deal with this, help them deal with this piece first. Like, it's all well and good that we want people to be successful and do all these things, but if we can't deal with the toxic stress they're experiencing, or the trauma, or those basic needs, the bottom of Maslow's hierarchy, like, we're never going to move them to those next steps. So what happens to the brain? So our amygdala is what activates that stress response. And you know, when you think about children in particular, right, we know their brain isn't fully developed. So even on the best of days, it's hard sometimes to make good, well-informed decisions because they just can't yet. And so if you have your amygdala activating the stress response, especially if that stress response is constantly being released, so you're in that high state of fight or flight all the time, think about how much more difficult it is for you to think, you as an adult, to think rationally and clearly when you're very stressed. I know I don't do my best work in that moment. So imagine children who already have a difficult time kind of processing and making decisions, and then being in that constant state of high level stress.
Shelly?
Yeah.
The flipped lid.
Yeah.
Dr. Dan Siegel, has anybody heard of Dan Siegel? The flipped lid, and that's kind of just an analogy I use with my nursing students and my, you know, patients, because I do also work with kids, child and adolescents, and this is the flipping of the lid. So when the stress response is activated, that prefrontal cortex goes offline and their lid is flipped. So it's kind of a simple way to explain what happens when you're having that stress response.
So kind of going back to kind of the premise of the day, right? We're talking about potentially women who are pregnant, having children, what's happening to these young children when they're born and they're coming into an environment where maybe there's trauma or substance use or other mental health issues. When babies are born, right, it makes sense. What do they know how to do? Sleep, eat, and cry, right? Like, they're born with the neurons, they're born with the ability to do just the things that they need to know how to do to survive. As we grow, as children grow, they develop these other pathways that tell them how to respond to the new things that are happening in the world around them. What happens in early childhood, sometimes before children even remember, is we develop all these experiences, and then the simplest way to put it is the ones that we don't experience as often, they get pruned, they go away. So imagine that you're a child in a household where there's neglect, where there's substance abuse, where there's violence, And that's happening more regularly than somebody who's nurturing you and picking you up and loving you. That's the experience that stays in that brain as that brain develops. And I see it all the time. So my agency also runs a child advocacy center for Delaware County, and I hear it all the time. Like, you have a 2-year-old child who's experienced serious abuse. And I'll hear somebody say, well, they seem fine. Well, of course they do. They're 2. But when we will see that impact is when they're in adolescence. And so now we have a middle schooler who we're like, why can't they behave at school? They've always been such a good kid. Well, we don't always see the impact of trauma until many years later. Not only that, but we don't always remember the things that happened to us in childhood. And so, and I want to be very clear that even if our brain doesn't remember, our brain doesn't remember consciously, our brain and our body does remember that trauma. And it does affect us as adults. And I think that, probably many of us in this room have experienced trauma when we were children. And now here we are, maybe experiencing our own trauma as adults and also working with people with trauma. Like, think about how complicated that is and how important it is that we do have strategies for resilience, that we do have strategies to support one another, because this work is hard and all of these things take a toll on all of us.
So statistics, both locally and nationally. So before I get into all the ACE-specific statistics, I think it's important just to talk about nationally the statistics in terms of child maltreatment and how common it unfortunately is. At least 1 in 7 children have experienced child abuse or neglect in the U.S., and these statistics are from 2020. They're from the CDC. And probably, as it says here on the slide, but it's most likely an underestimate. A lot of, these are all, the statistics they have are what was reported, what's been founded. So these statistics are probably higher than that. Children living in poverty have more abuse and neglect, and the rates of child abuse and neglect are 5 times higher for children and families with low socioeconomic status. So it's really critical that we support these families. They need our help the most. So really starting to think about these individuals are more at risk, and they're, as the conference is about reducing stigma, they're being stigmatized, and we really need to work as healthcare providers and as human service providers and those of us working with these individuals, recognizing they need the most help. And in 2020, the amount of children that died because of abuse and neglect is pretty astounding. And unfortunately, parents are more likely to be the perpetrators of children who suffer maltreatment and neglect. And likely those parents have their own issues, their own trauma that they haven't healed and they haven't worked through or built resilience. So that's just something else to think about. So it's just so critical to help start to build these skills in our communities for individuals. And this is a slide from the CDC I really like. It just kind of gives that visual of the economic toll. I hope you guys can see it okay out there. But the yellow is the productivity lost, and the light green is the amount spent on health care, and the darker green is special education, and child and welfare is I think like a darker green, and then the last one is the amount spent in the criminal justice system. So this is the economic toll, the estimated economic toll associated with child maltreatment. So that's pretty astounding if you look at that. So how, we have a lot of work to do to kind of reduce these numbers there and the amount spent where we can prevent a lot of this and help to build skills and build resilience. This is another statistic that came from the National Alliance on Mental Illness, and I think it breaks it down really simply. You guys can see that anxiety disorders are the most prevalent in our nation, 19%, and then PTSD, 4%, 8% depression, so you kind of can see an 8% with substance use disorder and mental illness. And I would suspect that might even be higher. This is the behavioral risk factor surveillance system, and we started collecting the ACE data in New York State in 2019. That's where that started. So this is the statistics in our communities in the region. So I found this it says it down there, but it was from the New York State website. They have collected this data through the BF, the Behavioral Risk Factor Surveillance System. So this is the percentage of individuals in these communities who had 2 or more ACEs. And this is a self-report system where phone calls are made out into these communities and they ask these questions about, and they might do it differently than just phone calls nowadays, but that's how it started, because that's been going on for decades. So as you can see here, Greene County is actually, Shenango County and Greene County are the highest, with Delaware County running 3rd place. So our statistics are higher than our statewide statistics in terms of people who've experienced ACEs. So we know the risk is in our region, it's in our communities. And this I'm not going to talk too much about but anyway, I have a study underway and I have some preliminary data I was going to share, but most of my, the participants, it's all self-report. So far I'm seeing, and I haven't analyzed it all, it's still underway, but there's a lot of ACEs. And we can flip through these few slides because I don't think I have time to talk about them all, but I do want to just, this is probably the only one I want to talk about. This is from my study that's underway. There was 114 respondents so far. I still need to collect some more respondents until I really want to analyze it, but just check out those frequencies there. So this is, again, my study, so it's preliminary, but Delaware County, has the highest, probably because I promoted it most in Delaware County. That's probably why that's the highest there. It just hasn't gone out to the others because we're looking for all rural counties.
So what we wanted to also talk about was just kind of anecdotally, some of the things that we see, and I think some of these things are probably not unique to our agency and are similar to things that you're seeing. But I think particularly during and post-COVID, I think we're starting to see, we are starting to see people with a lot more significant needs. Trauma that has been triggered or people that have been re-traumatized, whether it's by systems, which I'll circle back to in a minute, or other loss or other things that have happened. I know that some of the individuals that we work with that maybe have been in recovery or have been receiving treatment for mental health issues, in some cases because of things or trauma that happened during COVID have maybe taken some steps backwards and need to kind of get reconnected to supports. People are angrier, people are needier. And we purposely at our agency choose not to use the ACEs tool as like an intake mechanism. We believe that trauma-informed care should be a universal precaution because I don't know on any given day anybody who walks through my door, staff or clients, who's experienced what or what's going to happen in that day that might re-trigger them. And so we try to approach every interaction at all levels of our agency through a trauma-informed lens. And that's what, I guess that's what makes me want to be here today, is helping to, I guess you could call it one of my personal missions, is help to build awareness of this and help other organizations be trauma-informed as well. Especially, I can only really speak for Delaware County or even Shenango County because those are counties that I've worked in, but one of the challenges sometimes is the systems we have in place don't always work the way they're intended to work, right? And so many of us work with other agencies, other services, and sometimes one of the biggest challenges we have and one of the biggest triggers for people is when those systems really don't work the way that they were intended. And so part of our, sometimes we can't change or fix somebody else's system, but I feel like every organization here that continues to do this kind of work, it has a ripple effect, and then slowly but surely more people kind of come on board with those strategies. So I just want to mention that one of the ways that we look at responding to trauma is through this 4 R's model, where we realize, recognize, respond, and revisit traumatization. So what this basically means is within an organization, within a system, we want to realize that at all levels of the organization, there has to be a basic understanding of what trauma is, how it impacts people, what trauma-sensitive practices look like, and not just your physical interaction with someone, but your physical environment, your policies and procedures, all aspects of your organization. We want to recognize that all workers within the organization have the tools. So it's one thing to talk about it. It's totally another thing to know how to like go out in the world and operationalize it. So making sure that there's time for practice and skill building so that people really know how to interact with folks in a trauma sensitive way. Response, organizations responding to crisis by fully integrating universal principles of trauma-informed care. I'm going to talk about those on the next slide, but really being responsive in a way that really promotes the values and principles of being trauma-informed. And then, of course, avoiding any kind of practices that create re-traumatization, because obviously the last thing any of our agencies would want to do is make a path more difficult for somebody who's already having a difficult time. So these are actually 5 of the 6 principles of trauma-informed care. So the first way we can kind of build this trauma-sensitive culture is by creating safety. I think above and beyond anything else, if people don't feel safe, none of the rest of what we're talking about matters. And for many of our folks, whether they're pregnant and parenting or not, safety is a real concern. And so figuring out together how to build safety within our organization, within our systems, within our practices is really important. Giving people choice, right? Nobody likes to be told what to do. It doesn't really go well. Most, if not all of my staff are trained in motivational interviewing. We talk a lot about I always think about the guidance counselor model. When you're in high school, you go to the guidance counselor tells you what you need to do to get into college. That's not our job. We're not guidance counselors. I kind of see our job as kind of like we're coaches. Like we're telling you, here's kind of all the information we can share with you. We'll help you go along the path of developing your skills, but then you're going to decide what the right next step is. So I feel like our job is very different than that of a guidance counselor, but every once in a while I think human service professionals fall into that trap of, why didn't they just do what I told them to do, which we know rarely works. So giving people choice. Collaboration, so making decisions with the individual, sharing power, not playing the role of like, I have power, you don't, let me do this for you, but really coming together. That's why I really, really love the peer model. It's relevant, it's a true collaboration of coming together to support individuals. Being trustworthy, I think you've gotta put your money where your mouth is, right? If you say you're going to do something and you say you're going to practice it in a certain way, then you got to follow through. And I think with trustworthiness comes transparency, being upfront with people about what the approach is going to look like, what steps need to happen. I was talking about this at a presentation the other day, like if you have to call law enforcement, being really upfront with why you have to do that you'll be there to support them, like not blindsiding people. Empowering people. Ultimately, at the end of the day, we want people to feel empowered to make their own decisions and feel confident about those decisions. And the new value that's not on this one that has come from some of the other researches related to culture, gender, racial issues. Mm-hmm. So being mindful of that in our practices is really important as well. I guess I'll open it up to questions then.
I think somebody could walk away from here though and thinking that the problem is people who are poor. And I've had concerns about that just as we think that people who use substances, there's a flaw in their character, we think people who are poor are flawed, that there's a flaw in their moral character. And that has come since Elizabethan times. And we've hung on to that. And I wondered if you could speak to this issue of how we're stigmatizing people who are poor, often through no fault of their own. And how.
So for people that don't know, Delaware Opportunities is a community action agency. We're one of 1,000 across the nation, and our sole mission is really to help individuals who were living in poverty, who need help kind of gaining the skills to be self-sufficient. So I encounter this every day, and I think one of the things we didn't mention earlier is trauma. There's a lot of evidence to support that trauma can be intergenerational. Certainly living in, trauma doesn't discriminate based on socioeconomic status, but I think disproportionately those living in poverty are impacted more, and because oftentimes they have less opportunities to build resilience, they have less protective factors. And I think in the same way, we have to continue to talk about individuals living in poverty, or at the same time that we're talking about those with substance use disorder and reducing stigma, I think we have to do the same thing for people living in poverty. I hear people say all the time, I had a staff member said to me recently, like, if they just got a different job, like they'd be able to provide more for their family. And so talking about the complexity of poverty, I think is just as important as sitting here and talking about trauma. But I think the answer to your question is there has to be more education about what poverty looks like. We actually have access and are charged with, we haven't had a poverty simulation in our community in a really long time, and so our agency actually has have the tools to do a poverty simulation, and I think it would be really great to start the dialogue around how do we reduce the stigma and the blaming of those living in poverty for their circumstances.
Is that something that you do with schools?
We can do it with anybody.
What's a poverty simulation?
So a poverty simulation is an activity, it's kind of like a sensitivity training almost, if you've ever done something like that, where it walks you through what it would be like to live in the shoes of somebody who's living in poverty and have to make the decisions that they have to make within the circumstances that they have. And it really gives you an opportunity to see firsthand how complex it is. And it's not just as simple as getting a better job, which is often, I think, what we think. Or, you know, we have systems in place right now that you actually get more services if you don't work. And if you do work, you can't pay for things and you lose your services. So we've created a system that's kind of a no-win situation for some of the people that we're working with.
People living in poverty areas and people that are, you know, just kind of like generalizations in terms of their outcomes.
Do you mean, I just want to make sure I understand you correctly, almost like having, like people with blinders on where they're not seeing like what's happening?
In terms of, you know, when you pick a particular area and just say, you know, this particular area has a higher chances of more poverty area,
Yeah.
and just kind of like not looking at the area, just like
Yeah.
you blindfold.
Yeah. It's funny that you say that. This is more related to substance use, but it's all of these things are interconnected. You know, I was part of leadership, presentation at Leadership Delaware. Did I say it right? Leaderful Delaware. And one of the conversations came up was about housing. There's a significant housing need. And we were talking about people with substance use challenges, and the sentiment was like, how do we overcome those communities where we were like, we don't want those people? And my immediate question was, what does that mean? Who are those? Those people are us. Like, what are you talking about? So I do think we do have that does exist in our communities, and I think all of this goes back to the larger discussion of continued conversations around breaking down stigma and having the right people at the table at the right time who can start to chip away at it. Are we going to move mountains tomorrow? No, but every time we do something like this, we chip away at it and we build supports, and we are able to provide support for people that really need it. And slowly but surely, I think, you know, together we can shift the culture. We're not going to get there overnight, but I think we can work on it.
I was very glad that you addressed the neurological, the brain piece. But I was wondering if you could briefly talk about, other than that your brain is damaged, there are some things that can be done.
Yeah.
It's not like, okay, your brain damaged.
Yeah.
You know.
That's such a good point, and that's the part we didn't get to.
Right. I just wanted to put the
Yeah.
and if you could do that.
Yeah. So, I mean,
Yeah.
protective factors are a great a way to, you know, build resiliency. And here's the thing, you have to have adversity to build resilience, right? But what we all do in this room is help people by providing protective factors or helping them develop skills to be resilient. And, you know, I sometimes share this, I sometimes don't. I have 7 ACEs. I think I'm doing okay. I'm here talking to you today. But that's because I had people in my life that helped me develop tools to be resilient. And I think that that's what all of our organizations are trying to do for the people we're working with. And particularly related to the neonatal abstinence syndrome grant, like working with women who either don't have children yet or might have children, and maybe even trying to mitigate that before those children are even born, or you know, as they're born. That can help us break that cycle of that intergenerational.
Intergenerational.
Yeah, I'm done. Yeah.
My question has to do with being a simple community member. So we all see these things going on in our neighbors, and I think my ACEs, and I have ACEs, but I also know that I had these countering effects. So at the same time that some of these issues and traumas were taking place in my life, I also had these wonderful, helpful, joyous pieces. So there was balance for me, and that is what helped me grow and continue in a positive vein. As a neighbor, a very simple message would be, or a simple question is, how could a neighbor seeing a child, knowing that things are happening that are counter to their healthy, positive development, what are the kinds of things a neighbor can do in a subtle, maybe subversive way to make sure they provide those little pieces of light?
You know, you always hear that phrase, like, one positive adult in a child's life, and I guess what I would say in a nutshell, that maybe Libby has an idea, like, I would say, first of all, we just need to be kind. But I also think that you being kind to that child, just being kind, talking to them, interacting with them, you may be the only person that does that in that child's life. And sometimes that makes all the difference in the world. So I feel, I know it sounds so simplistic, but I feel like we just need to start with being kind.
And research does suggest, because we had more to talk about here, but research suggests that that stable caregiver is a buffer. So any stable caregiver, it doesn't have to be a biological parent. It could be anybody, grandparent, coach, teacher. So again, that being kind and recognizing, that universal precautions for trauma-informed care, recognizing what's wrong with you, but what happened? How can I be there for you? That's kind of that paradigm shift. So really just being there for the people in our communities, getting involved, helping where you can, and getting to know, people, and it could make all the difference.
Before,
Know
Tiffany.
all of this that we know or are learning, the neighbor can be powerful.
Yes.
And I think as I'm listening to you, my brain's going to, how do we get that message out? Just by being nice.
Well, I think we keep talking about it, and we keep bringing these conversations to different places. And we share it with our friends and our families, and little by little that message infiltrates. I just want to give this woman a chance to ask her question real quick, just because she had her.
With Diane's in the school. She's been in the school, and I wondered to what extent are they doing trauma-informed?
I think it depends. I think it depends on the schools.
It definitely depends on the school, and it's a growing knowledge base.
The school I've most recently been connected to, it is a center point. There's a lot of conversation going on in that school, which makes me very happy. And I know that I am involved with ADAC, and we have folks here from ADAC, and I know that they are in the schools, and I know that that is a very important partnership. And trauma-informed care is the foundation of the work that ADAC is doing as well. So,
Well, and the governor has just allotted a whole boatload of money for mental health. There's new standards in place for school districts around mental health and social emotional well-being for students in schools. So while I definitely agree that it's growing, and schools will be doing a lot more because they're gonna have to. Did you still have a question?
Okay. I'm a longtime shrink,
Okay.
and I worked with PTSD before there was anything called PTSD. It was wonderful. How are you guys taking care of yourselves? Because that's a big part of it.
Yeah.
You mean self-care?
Yeah.
That exists?
Yeah.
Stop it!
Yeah.
Stop it!
So I actually do quite a lot of presentations on vicarious trauma and self-care. And as an organizational leader, I know you're asking about us, but as an organizational leader, it's very important to me that we build opportunities for self-care within our organization. And so sometimes my staff are like, why are we doing this? Like, we should be working. I'm like, this isn't, like, everything is very strategic. So we do a lot within our organization to build self-care together. I also think self-care comes from having positive relationships with people. And so having laughter and fun and camaraderie in the workplace does help to buffer some of the stress we feel on a day-to-day basis. And I think individually, we each have to figure out those things that we can do that help balance out this hard work that we do every day. And I try really hard to walk the talk, because I can't expect the people that are looking at me saying, you're telling me to do self-care, but you're not doing it. You know, so even being here today, like talking about this it feels good to me, because it's important. And it's a chance to bring people, to like-minded people together, that we can continue to support one another and strategize. But your point is well taken. Self-care is an important part of this conversation.
We have another question back here.
Yeah.
I just wanted to reflect on the new ACs you're talking about post-COVID. I know we've seen increase in trauma children in terms of mental health. I know the research you presented was year 2020. I was just wondering if new data or research is coming up post-COVID in terms of ACEs, new ACEs.
Yeah, there wasn't a lot now. I believe the one slide that broke down the counties, that was, if I remember correctly, 2021. So some of that was in the midst of COVID. You know, that's what I could find locally. I didn't look nationwide. I was just trying to pull local ACE data. But there are studies, you know, that are looking at this post-COVID. And certainly I think some of, you know, what happened during COVID, people were kind of dealing and managing their stress, you know, because we, as humans, we all experience stress. And then it just got to the point for those who were teetering to tolerable, it became just toxic all the time. And we're kind of dealing with that post, you know, again, like Shelly said, the child who's had an issue and it was abused, they're going to seem fine at first. It's later where we're going to see the effects of that.
And is there anybody here from DSS? I think probably if you ask DSS, one of the biggest indicators would be the jump in CPS cases, which significantly increased post-COVID. Yep, I was just thinking about this. So we just promoted during Domestic Violence Month. I think we served 300 children through our Safe Against Violence program. I think in 1 year we had close to 200 interviews through maybe over 2 years through the CAC, the Child Advocacy Center. So those are children that have been physically, sexually, in some fashion abused or neglected. So I think that speaks, even though it's not, you know, quantitative, you know, firm quantitative data, I think that just speaks to what we're seeing locally, the uptick in those kinds of situations happening and the need for interventions for families.